Welcome back to the Deep Dive, the place where we turn massive textbooks into actionable knowledge. We're here to give you the context, the anchors, and hopefully those aha moments you need.
That's the goal.
And our mission today is pretty sharp and focused. We're diving into Chapter 34 of Baily and Love's 28th edition Conflict Surgery.
And we need to be clear right up front. This isn't just us reading the chapter to you.
No, not at all. This is an interpretation. It's designed to anchor the critical, life-saving principles of surgery under, well, the most extreme duress imaginable.
Exactly. So if you're a medical student, a trainee, or honestly just curious about the real sharp end of surgery, think of this as your framework. We're building the scaffolding.
Right. So when you go back to the book, you'll know what's foundational and how all these pieces, the logistics, the ethics, the surgery fit together. It's your ready reckoner.
Your revision guide.
Yeah.
And the history here is just, it's incredible. You know, Hippocrates said, "He who wishes to be a surgeon must first go to war."
And it's still true, isn't it? So much of what we do in civilian trauma centers was born out of conflict.
It's ancient history. I mean, the Edwin Smith Papyrus, which is the oldest known text on trauma surgery, is from 1600 BCE.
Wow. So for thousands of years, we've been trying to figure out how to put people back together on the battlefield.
Yeah, trying to standardize it. But the real game changer, the shift from just treating a wound to managing a whole system of casualties, that was a logistical revolution.
And that really comes down to one person, doesn't it? Demain Larrey.
Larry, Napoleon's surgeon, he's the father of modern military surgery because he got it. He understood that the real enemy wasn't just the wound, it was time.
He was solving a logistics problem.
He was. He developed the ambulance volante, the flying ambulance, a rapid response mobile unit. That was the birth of modern casualty care as we know it.
Okay, so let's use that as our jumping off point. Let's set the scene. If you're a surgeon trained in a shiny, modern civilian trauma center, what are the absolute non-negotiable differences that define war surgery?
That's the perfect place to start. We need a really solid anchor here.
What's the anchor?
Just frame it in your mind like this. War surgery is trauma surgery under extreme duress. If you get that, everything else just falls into place. The differences become mandates, not just, variations in practice.
Okay, so let's run through them. Baily and Love lists 5 key contrasts. What's number 1?
First up, the austere environment. In your civilian hospital, you basically assume unlimited resources.
You've got specialists on call, CT, MRI, a fully stocked blood bank.
All of it, 24/7. In a deployed setting, even a top-tier Role 3 hospital is at the end of a very long, very fragile supply chain.
So you're always thinking about what you have and what you might not have tomorrow.
Constantly, that fancy bit of kit.
Yeah.
It depends on fuel, power, and the logistics guys getting it there. You operate knowing that your resources are fundamentally finite.
Which must change your decision-making from the very first cut.
It has to. You can't plan for a complex, multi-stage procedure that needs a dozen specialized consumables if you don't know you'll have them. The plan has to be about stabilization with what you've got.
Okay, so that's the environment. What's the second contrast?
The second is kind of obvious, but it's easy to forget when you're just focused on the clinical side. The hostile and dangerous environment.
You mean the fact that you, the medical team, are also at risk?
Yes. Your workforce has to be protected. Modern military medicine pushes surgical teams further forward to shrink that time to care.
So you're putting your forward surgical teams, your Role 2 facilities, closer to the fighting.
Which ramps up the personal risk immensely. Security, intel, force protection, they become just as important as scalpels and sutures. You're trying to save a life while you yourself are under threat. That's totally alien to civilian practice.
Right. Okay, number 3, different injuries. This gets to the actual pathology.
It does. Modern weapons deliver just a massive amount of energy. The injury patterns we see, these complex blast wounds, the cavitation from high-velocity rounds, the overwhelming contamination, you just don't see that in a civilian ER.
Not even in the busiest city trauma centers.
Rarely. These injuries demand very specific techniques for wound management, especially dealing with these huge zones of dead, devitalized tissue. We'll definitely circle back to that.
Got it. Number 4. This feels like a big one. Mass casualties situations.
This is where the whole ethical framework flips. In the civilian world, it's about maximal care for the individual in front of you.
You do everything possible for that one person.
In a mass casualty event or just in the relentless tempo of conflict, your mindset has to shift to resource optimization. The dictum is brutal, but you have to internalize it.
Say it for us.
Do the best for the most, not everything for everyone.
And that means making some impossible choices.
It does. It means a patient who might have been salvageable back home, but who would take up too many resources, too much time, too much blood, too many staff, might have their care bypassed for someone with a better chance who needs less. That is the hard reality of triage.
Wow. Okay, and the fifth and final contrast.
Staged delivery. The patient is, in essence, a package that has to keep moving down the line.
So care isn't just in one place. It's a chain.
An echelon of care. From the point of injury at Role 1, back through surgical care at Role 2 or 3, all the way to definitive care back home at Role 4. This means your initial surgery has to be done with that journey in mind.
You're not just stabilizing them to survive the operation.
You're stabilizing them to survive the next flight, which could be long and stressful. Stability for the journey is absolutely mandatory.
Okay, that sets the stage perfectly. Before we get into the mechanics of that care, we have to talk about the legal and ethical boundaries. You mentioned the framework flips, but it doesn't disappear.
No, it's governed by international humanitarian law, or IHL.
Which comes from the Geneva Conventions.
Primarily. And it grants rights and imposes duties. The most important, the binding medical ethic it enshrines, is the principle of neutrality.
Okay, let's unpack that, because it sounds absolute, but you've already said triage forces you to make choices. How does neutrality work in practice?
It means you treat patients based only on their medical need. You don't consider their nationality, race, religion, or their politics. Allied soldier, enemy combatant, local civilian, the most severely injured person gets treated first. Period.
But let's push on that with a scenario. Let's say you're in a Role 3. 2 casualties arrive at the same time. One is an Allied soldier who needs a 4-hour limb salvage surgery. The other is an enemy combatant with a massive bleed in their abdomen who needs a quick damage control operation, but will then soak up all your blood products and your only ICU bed for days. Triage says prioritize the one with the highest chance of survival for the least resources. Doesn't that mean the enemy combatant who has a massive resource drain gets pushed down the list? How is that neutral?
That's the absolute core of the conflict, isn't it? In a resource-crunched mass casualty scenario, the triage category dictates priority. It has to be a cold physiological calculation.
So it's not about who they are, it's about the math of survival.
Exactly. If treating the Allied soldier means 5 other salvageable patients will die waiting for the OR, the triage dictum takes over. But, and this is the key, if you have the resources and it's just a choice between those two, neutrality demands you apply the same medical assessment to both. Their uniform must never be the reason for the decision. Only need and resource allocation.
Okay, that's a critical distinction. The resource calculation itself is part of the ethical framework.
It is. Now let's talk about another ethical challenge the book highlights, dealing with the local population.
Right, the limb salvage scenario, where you can do the fancy surgery, but maybe you shouldn't.
Let's make it real. You're treating a local civilian, a bad leg wound. You have the skills to do a complex vascular repair, save the leg, the technical success, right?
Sounds like it.
But you know for a fact that they'll be discharged into a community with no physical therapy, no prosthetics, no way to manage a chronic infection.
So the leg you saved becomes a useless infected limb.
And they end up needing an amputation months later anyway, but under much worse conditions. So is it more ethical to do a planned, clean amputation early on, giving them a stump they can actually use with a locally made prosthetic?
Wow. So you have to factor in the entire societal context into your surgical plan.
It's a profound responsibility. You're making decisions civilian surgeons rarely, if ever, have to confront. And wrapped around all of this is the final point. Facility security.
The Geneva Conventions are supposed to protect medical staff.
Supposed to. But in unconventional warfare guerrilla conflicts, no clear battle lines, that protection is fragile. Medical facilities can be targets.
So security isn't just a guard at the door.
It's a core operational capability. You can't care for patients if you can't protect the caregivers. It's as simple as that.
Okay, let's define the structure that manages all this. The roles of care. R1 to R4. This is a key anchor for anyone studying this.
Absolutely. Just think of them as tiers of increasing medical sophistication as you move away from the point of injury.
So let's start at the very front, Role 1.
Role 1 is at the unit level. It's the medic, the corpsman, embedded with the troops. They're doing advanced first aid stopping bleeding with tourniquets, basic airway stuff, starting fluids. Their one and only goal is to stabilize that casualty enough to get them to the next level.
And that next level is the first place they can see a surgeon, Role 2.
Role 2 is the pivot. This is an intermediate facility. Its mandatory capability is damage control surgery, or DCS.
So they can do the life-saving stuff. Open a chest, open a belly, stop the bleeding.
Exactly. Abbreviated life-saving operations. It's a very limited holding facility. The goal is operate, stabilize, and then get them out and back to Role 3 as fast as possible.
So Role 2 saves the life, and Role 3 provides the more sophisticated care.
That's a great way to put it. Role 3 is your deployed hospital. It's got specialists, ortho neurosurgery, general surgery, and advanced diagnostics like CT scanners and a proper lab.
And crucially, a big blood bank.
A very big blood bank. They can handle multiple massive transfusions at once. They're the ones who really manage that complex resuscitation phase after damage control surgery, and they stabilize the patient for the long flight home.
Which brings us to the end of the line, Role 4.
Role 4 is definitive care. It's back in the home country or maybe an allied nation's hospital. This is where the complex reconstructions happen, the long-term rehab, all the things that are too resource-intensive to do in the theater of war.
Okay, so a quick check-in question for you listening. A casualty comes in, they're in profound shock, they need their belly opened and packed, and their pelvis needs an external frame put on. They're way too unstable for a long flight. What is the minimum role of care required for that intervention?
The answer has to be Role 2. Role 3 would be ideal, of course, but the minimum capability for that life-saving damage control surgery is Role 2. If you didn't get that, just rewind a bit and anchor in your head. Role 2 equals DCS capability.
Perfect. So the moment a casualty is injured, that clock starts ticking.
Yeah.
Let's talk about how we beat that clock. Let's talk about time, triage, and damage control surgery.
Time is the ultimate resource. And aeromedical evacuation helicopters, fixed-wing planes, is the backbone of the system.
But moving a critically injured patient is inherently risky.
It's incredibly dangerous. You have to stabilize them before you move them. There's a non-negotiable checklist.
What's on?
Airways, number one, often means you have to intubate them. All your 5E lines, your monitoring lines have to be rock solid, and critically, you have to keep them warm.
Hypothermia, part of that lethal triad.
Exactly. Acidosis, coagulopathy, and hypothermia. And the cold cabin of an aircraft at altitude will make it so much worse. You have to be actively rewarming them from the get-go.
And there's a specific risk with chest injuries during air travel, right? Urotrauma.
Yes. If a patient has a lung injury, especially a blast lung injury, the change in pressure as the plane climbs can cause a tension pneumothorax.
Which would be catastrophic mid-flight.
Lethal. So a crucial preemptive step is to consider putting in prophylactic chest tubes before they take off. It's a minor procedure on the ground that prevents a fatal complication in the air.
Okay, let's tackle the big concept everyone's heard of, the golden hour.
Ah, yes, the golden hour. The idea, which came from Dr. R. Adams Cowley, is that there's this window of time right after injury where intervention is most likely to save a life.
People debate the hour part, but the principle holds true in combat, doesn't it?
It absolutely does. The vast majority of preventable deaths from combat trauma happen before the casualty ever reaches a surgeon. They bleed out.
So the modern military strategy is twofold.
Yeah.
You either have to shorten the timeline to get them to a surgeon,
Right. By pushing surgical teams further forward using those Role 2 facilities.
or you have to find a way to lengthen the golden hour itself.
And that's where we've seen a radical shift in pre-hospital care. We've gotten very aggressive with hemorrhage control tourniquets, hemostatic dressings, but the real game changer is pushing blood products forward.
You mean giving blood in the field?
Yes. Giving whole blood pre-hospital or using walking blood banks where screened soldiers donate fresh blood on the spot. It means we start resuscitation the moment we get to the patient, buying them crucial time to get to the operating room.
That's incredible. Now, the nature of these injuries has also changed dramatically. The data from Iraq and Afghanistan shows a huge shift.
A fascinating shift, and it's all because of body armor.
What does the data show?
Compared to older conflicts like Vietnam, we see far more head and neck injuries, but we see far fewer thoracic and extremity injuries.
Because the body armor is working. It's protecting the torso.
It is, but the parts that are still exposed, the head, the face, the limbs, now take the full force of the trauma. The protection just shifts the injury pattern. But the biggest change, the one that defines modern conflict surgery, is the mechanism.
Explosions.
Overwhelmingly explosions. Let's just put some numbers on that. In the U.S. Civil War, something like 91% of wounds were from gunshots.
Okay.
In Iraq and Afghanistan, it's completely inverted. 81% explosion, 19% gunshot. The main cause of injury and death is now blast from IEDs, mines, and mortars.
Which means the core principles of war surgery have had to adapt. Death is either immediate from hemorrhage or later from infection.
And so the immediate focus has to be on stopping the bleed, tourniquets for the limbs, and for the torso, where you can't use a tourniquet, you need advanced techniques to get control of that bleeding fast.
Which brings us to the foundational surgical strategy for all of this. Damage control surgery, DCS.
Yes. The anchor you need to remember is DCS is stabilize weight, then fix. It's a deliberate strategy that prioritizes physiology over anatomy.
You're intentionally doing an incomplete operation.
And you are. You're going in, you're addressing only the immediate life threats, the bleeding, the gross contamination, and then you're getting out. You pause the surgery to let the patient's body recover metabolically.
How do you decide who needs it? Is there a clear line?
There's no single magic number, which is why judgment is so critical. But you look for the signs of profound shock, severe hypothermia, a core temp below 35 Celsius, coagulopathy, profound acidosis, massive blood loss.
So if a patient is that sick, attempting a long, perfect, definitive repair is just going to kill them on the table.
It'll push them right over the edge. You have to do DCS.
Okay, another check-in question for our listeners. There are 4 phases to DCS. Before we go through them, just take a second and try to map out that patient's journey in your head, from the OR to the ICU and back again.
It's a crucial pathway to understand.
All right, let's walk through them. Phase 1.
Phase 1 is recognition and resuscitation. It starts the second you decide this patient needs DCS. You're getting warm fluids in, getting big IVs, and moving urgently to the operating room. It's all about speed and preparation.
Phase 2 is the surgery itself.
The abbreviated surgery. Your goals are simple. Control bleeding, pack the liver, clamp the vessel, and control contamination staple off the bowel, wash out the belly. The whole thing should be done in under an hour, maybe 90 minutes max. Then you put on a temporary closure and get them straight to the ICU.
Which is phase 3, their charge phase.
And this is arguably the most important and complex phase. This is where the intensive care team takes over. The goal is to normalize the patient's physiology. You're correcting the acidosis, you're warming them up, and you're fixing the coagulopathy.
And how long does that take?
It can take 24, even 48 hours. You don't move on to the next phase until they are physiologically optimized, warmed up, making urine, and crucially, their blood is clotting properly.
And when they're stable, you go to phase 4.
Phase 4 is the definitive repair. You take them back to the operating room. Now you can do the elegant surgery. You take the packs out, you repair the vessels properly, you connect the bowel back together. And this might take several more operations to get to the final result.
And running alongside all of this is something called damage control resuscitation, DCR.
Yes, DCR is what's happening while the surgeon is operating. It's how you manage the patient's blood and clotting system. The first principle is permissive hypotension.
Meaning you let the blood pressure stay low on purpose?
To a point. You keep it just high enough to perfuse the brain and heart, maybe a systolic of 80 or 90, but low enough that you don't blow off the fresh clots that are forming.
And the second rule is about fluids.
It's an absolute rule. Avoid crystalloid, saline, ringers. They are the enemy of a bleeding trauma patient. They dilute the clotting factors, they make the acidosis worse, they don't carry oxygen, they're just salt water.
So instead of crystalloid, you do hemostatic resuscitation?
Meaning you give blood products. Early and often. Red cells, plasma, platelets. You're replacing what the patient is losing.
The exact ratio of those products has been a big debate, hasn't it? The whole 1-to-1-to-1 thing.
It has. Retrospective data suggested a 1.1.1 ratio of plasma to platelets to red cells improves survival. The debate now is more about logistics and priorities. Is that exact ratio achievable in an austere setting? Or is it more important just to get any blood products in fast and, most importantly, stop the bleeding first?
The best resuscitation is stopping the hemorrhage.
It's useless without it.
Okay, let's go back to our case.
Yeah.
Soldier with a high-velocity wound to the flank. He's cold, his pH is 7.1, he's already had blood in the field, he's on the table. Checking question. His pH is 7.1. Should that surgeon spend the next 2 hours doing a perfect bowel resection and anastomosis? If you just thought yes, please rewind and listen to the core principles of DCS again.
The answer is a hard no, an emphatic no. That patient is profoundly acidotic. Attempting a definitive repair is a death sentence. The surgeon has to do the damage control op, staple the bowel, pack the bleeding, and get to the ICU for phase 3 resuscitation. Anatomy can wait. Physiology cannot.
And all of this requires a huge amount of blood, which means you need a massive transfusion protocol.
You do. And MTP is essential. It's a system that allows the blood bank to release large quantities of blood products immediately, without delay, and that requires a massive logistical tail to keep that blood bank stocked in a war zone.
Incredible. Okay, let's shift gears from logistics to physics. To manage the injury, you have to understand the weapon. Let's talk ballistics.
Right. At its simplest, a firearm is just a controlled explosion that pushes a projectile down a tube, but the wounding potential is all about what happens next.
Okay, another check-in question for you. There are 3 types of ballistics. Can you name them and where they happen?
Let's see. First is internal ballistics. That's everything that happens while the projectile is still inside the weapon. The most important thing here is the rifling, the spiral grooves in the barrel.
That's what makes the bullet spin.
Exactly. And that spin stabilizes it in flight. Without it, it would just tumble end over end.
Okay, so then it leaves the barrel. That's external ballistics.
External ballistics. The bullet in free flight. This is where you see the big difference between a high-velocity rifle round and a low-velocity pistol round. The rifle bullet is designed to be aerodynamic and maintain its speed, and therefore its energy over a much longer distance.
And finally, the one that matters most to us, terminal ballistics.
Terminal ballistics, or wound ballistics. This is the interaction between the bullet and the target tissue. This is where the kinetic energy gets transferred to the body.
And the formula for kinetic energy is 1/2 mass times velocity squared.
Velocity is squared. That's the key. A small increase in speed results in a massive increase in energy and potential injury. That's why a military rifle round is so much more devastating than a handgun round.
Even if they weigh the same.
Even if the mass is similar, it's all about the velocity. And the bullet's construction matters too.
You mean like Full Metal Jacket versus a hollow point?
Right. A full metal jacket, or FMJ, is designed to penetrate. It holds its shape. A hollow point is designed to deform and expand on impact. It dumps all its energy very quickly, creating a bigger wound, but with less penetration.
This brings us to the core concept for understanding gunshot wounds. The permanent versus the temporary cavity.
This is such a critical anchor. Every high-energy wound has 2 components of injury.
Let's start with the easy one, the permanent cavity.
The permanent cavity is the actual hole. It's the tissue that was directly crushed and torn by the physical passage of the bullet. In a low-energy handgun wound, this is often the main source of injury.
But in a high-energy military wound, the real damage is often from the temporary cavity.
The temporary cavity is the invisible killer. It's caused by the massive lateral displacement of tissue as the huge amount of kinetic energy is transferred. The tissue stretches violently outward, far beyond the path of the bullet, and then snacks back.
You had a great analogy for this, throwing a stone into thick mud versus a pool of water.
Let's apply that to the body. It's all about the tissue's elasticity. Tissues with good elasticity, like muscle, skin, or lung, can stretch and rebound with minimal permanent damage.
But what about tissues that aren't elastic?
Tissues with poor elasticity, the solid, dense organs like the liver, the spleen, the brain, they can't tolerate that stretch. When the temporary cavity expands through them, they don't stretch, they shatter, they literally fragment.
So a rifle round that passes cleanly through a thigh muscle might be manageable. But that same round passing through the liver would be absolutely catastrophic.
Catastrophic. And hollow organs, like the bowel or the bladder, are also very vulnerable because they're filled with fluid, which is incompressible. The energy wave passes right through the fluid and can cause them to rupture, even if the bullet itself misses.
This explains why the management of military gunshot wounds is so much more aggressive than civilian ones.
It has to be. In civilian practice, you might manage a stable patient with a pistol wound to the abdomen non-operatively. You'd never do that with a high-velocity military rifle wound.
Why not? If the patient is stable, why not just watch them?
Because the full extent of that temporary cavity damage is often hidden. It's clinically occult. A CT scan might not show it. The tissue looks fine, but it's been devitalized. It's dead.
And if you leave dead tissue inside someone,
you're guaranteeing a massive deep-seated infection. That's why the mandate for most military penetrating wounds is surgical exploration. You have to go in, you have to look, and you have to debride. You have to cut out any tissue that looks non-viable.
And this again points back to staged surgery, to DCS.
It does. That interval in the ICU, that phase 3, allows the body to reperfuse. When you go back for phase 4, the line between living and dead tissue is much clearer. You can do a much more accurate and effective debridement.
Okay, let's shift from ballistics to the signature injury of modern war. blast injuries, a whole different kind of
A
physics.
completely different mechanism, and it all comes down to the speed of the explosion.
Low versus high explosives.
Right. Low explosives like gunpowder, they deflagrate. The reaction moves slower than the speed of sound. They mostly cause burns and push things. High explosives, TNT, C4, they detonate.
Meaning the reaction propagates as a shock wave, moving at supersonic speed.
Exactly. And that creates the blast wave. The anchor for understanding this is the Friedlander curve.
Describe that for us.
The detonation creates this sphere of super compressed air. The Friedlander curve shows what happens to the pressure at a single point in space. You get this near instantaneous massive spike in pressure, the blast over pressure.
And then what?
Then it decays exponentially, and it actually drops below the normal atmospheric pressure for a moment. This creates a partial vacuum, the negative pressure phase.
And why does that negative phase matter?
That vacuum can actually suck objects and people back towards the blast center. It contributes to the chaos and the trauma.
And the environment changes everything. An explosion in an open field is very different from one in a building.
Hugely different. In an enclosed space, the blast wave reflects off the walls. Those reflections compound, sustaining the high pressure for much longer and massively increasing the injury severity.
Briefly, before we move to the injuries themselves, what about more complex devices like EFPs, explosively formed projectiles?
EFPs are particularly nasty. They're a type of shaped charge that uses the explosive energy to turn a metal plate, usually copper, into a molten high-velocity slug.
Designed to penetrate armor.
Exactly. It punches through the side of a vehicle and then causes just catastrophic damage to the occupants inside from fragmentation and blunt force.
Okay, so to understand the injuries, we have to classify them. There are 5 types.
Right, the 5 categories. It's a useful way to think through the different ways a blast can hurt someone.
Let's list them. Primary is from the overpressure wave itself. Secondary is from fragments. Tertiary is from being thrown.
Quaternary is everything else, burns, crush, injuries. And quaternary is from any additives to the bomb, like radiation or chemical agents.
Let's focus on the primary injuries. These are the unique ones caused directly by that pressure wave.
And they specifically affect the organs that have an air-tissue interface. The most common one is a ruptured eardrum or tympanic membrane.
But the most lethal primary injury is blast lung.
Blast lung injury, or BLI, is devastating. The shock wave passes to the chest wall and just shreds the delicate membranes between the alveoli and the capillaries.
So you get bleeding and fluid buildup inside the lung.
Yes, leading to progressive hypoxia. And often there's very little sign of injury on the outside of the chest.
What's the complication that makes BLI so deadly?
Air embolism. If the blast rips a hole between an air sac and a pulmonary vein, air can get directly into the bloodstream.
And that air bubble goes to the brain or the heart.
And it's lights out. Acute cardiovascular collapse. It's a leading cause of immediate death from blast.
How do you diagnose it?
It's mostly a clinical diagnosis, but a chest x-ray will often show a characteristic bat wing pattern of infiltrates. And the management, again, comes back to thinking ahead.
The prophylactic chest tubes we talked about earlier.
Because of the high risk of the lung rupturing and causing a tension pneumothorax, especially during evacuation, you have to strongly consider putting chest tubes in preemptively.
The gut is also really vulnerable to primary blast, isn't it?
Very, especially the parts of the bowel that contain air, like the cecum. And the scary thing here is that the presentation can be delayed.
So a soldier can look fine initially?
They can, but the bowel wall might just be severely bruised. Over the next day or two, that bruised tissue can die and perforate, leading to full-blown peritonitis.
Which creates a huge surgical dilemma if you're operating on them for another reason.
A massive one. Imagine you're in the belly and you see a segment of bowel that's dark and bruised but not actually perforated. What do you do?
If the patient is unstable, it's easy, right? You just pack and plan to come back later.
Right, DCS rules apply. But what if the patient is stable? Do you resect that bruised segment now, potentially taking out bowel that might have survived? Or do you leave it and risk them coming back in septic shock in 48 hours when you might be in the middle of another mass casualty?
There's no good answer, is there?
There's no easy answer. But in a deployed setting, most would err on the side of caution and resect it. You can't risk a delayed catastrophe if you can't guarantee a timely second look.
Okay, let's move to secondary blast injuries.
The fragments.
The shrapnel. This is where the physics gets interesting again.
Remind us of the two dissipation laws.
The primary blast overpressure energy dissipates very quickly. It follows the inverse cube law. You have to be very close to the blast to be killed by the pressure wave alone.
But the fragments travel further, much further. Their energy dissipates according to the inverse square law, which is much slower. The operational implication is huge.
Was it?
It means the lethal radius for fragmentation is far, far greater than the lethal radius for the primary blast. The fragments are the persistent long-range threat.
And they create nasty, irregular wounds.
They're chaotic, they tumble and yaw, and they are inherently grossly dirty, carrying soil and clothing deep into the tissue.
So management is all about cleaning them out.
Aggressive debridement.
Yeah.
And the same rule applies as for ballistics. You manage them with serial debridement and delayed primary closure. You never, ever seal that contamination in.
Okay, let's move into our final section, looking at some of the complex injury patterns that have really defined recent conflicts and the overriding battle against infection.
Right, let's start with the tertiary injuries. This is just the blunt trauma component.
From being thrown by the blast wind.
Exactly. Fractures, head injuries, internal organ damage from the impact, traumatic amputations often fall into this category as well.
And then there's these very distinct patterns. The first is the underbody blast, or UBB.
This is what happens when a vehicle hits a mine or an IED. The shock wave travels up through the floor of the vehicle, causing this massive vertical acceleration.
And the injuries are predictable.
Very predictable. Severe foot and ankle fractures, pelvic fractures, and injuries from the organs being violently shoved upwards. Aortic tears, liver lacerations.
And then there's the pattern that has become the hallmark of the dismounted soldier. The dismounted complex blast injury. DCBI.
DCBI it's the definition of devastating multi-system trauma. It's typically a pattern of one or both legs amputated, a severe open pelvic fracture, and extensive injuries to the genitals, perineum, and rectum.
The initial management for that must be just dry and gently. Pure hemorrhage control.
That's all that matters in the first few minutes. Tourniquets, high and tight, but the pelvic bleeding is the real killer.
And you can't put a tourniquet on the pelvis.
We can't, which is where advanced concepts like Reboe come into play.
Resuscitative endovascular balloon occlusion of the aorta. Let's break that down.
Reboe is a technique where you thread a balloon catheter up into the aorta, usually from the femoral artery, and you inflate it.
Like an internal tourniquet.
Exactly. It stops all blood flow below the balloon, buying the surgeon time to get control of massive bleeding in the pelvis or abdomen.
But there's a huge non-negotiable caveat for using this in a military setting, isn't there?
A critical one. Time. Reboe is a bridge to surgery, not a solution. In a civilian trauma center, that bridge might need to last 30 minutes.
But in the military, with long evacuation times.
If you inflate that balloon and that patient then have a 2-hour flight to get to a surgeon, you've just traded death from hemorrhage for certain death from ischemia. All their internal organs, their spinal cord, their legs, they've had no blood flow for hours.
So it has to be used with extreme caution.
Extreme caution, and only when you have a guaranteed rapid path to the operating room.
And the surgical repair of a DCBI requires a whole team.
Absolutely. Orthopedics to fix the pelvis, general surgery to deal with the bowel and rectum, often requiring a colostomy, and urology to manage the bladder and urethral injuries. It's a massive team effort.
And this brings us full circle, back to the late killer, infection.
The second enemy. The anchor here is simple. Every single battlefield wound is, by definition, grossly contaminated.
The blast itself drives dirt, clothing, everything deep into the tissue.
Into a massive zone of dead, devitalized tissue that has poor blood supply because the patient is in shock. It's a perfect storm, a perfect culture medium for bacteria.
What kind of bugs are we worried about?
Everything. From the common skin bugs like staph and strep, to nasty gram-negatives from the soil and bowel, to the really aggressive hospital-acquired bugs like Acinetobacter that we see in long-term patients. And you always have to be thinking about tetanus.
So what's the most important treatment? Is it antibiotics?
Antibiotics are important, but they are a distant second. The absolute mainstay of treatment is surgical control.
Debridement.
Prompt, aggressive, and repeated debridement of all non-viable tissue. If it's gray, if it doesn't bleed, if it doesn't contract, it has to be cut out. And you have to open the wound wide to let it drain.
What about washing the wound out?
Copious irrigation with saline is key, but there's an important detail. You must avoid high-pressure lavage.
That seems counterintuitive. Wouldn't a power wash be better?
It seems like it would, but studies show that high-pressure jets can actually drive bacteria deeper into the healthy tissue planes. You're spreading the contamination, so gentle, copious irrigation is the rule.
And now for the final, fundamental, non-negotiable rule of war surgery wound care.
With a very few, very specific exceptions, like some facial wounds, you never ever close a contaminated war wound at the first operation.
Why not?
Because if you seal in that bacteria and dead tissue, you create a perfect anaerobic incubator. You are setting the patient up for a life-threatening infection like gas gangrene. It's malpractice.
So instead you do delayed primary closure, DPC.
The wound is debrided and left open. You pack it with clean, moist dressings, maybe use a wound VAC, and then you take the patient back to the OR every 24 to 48 hours for another look.
And you just keep debriding.
You keep debriding until the entire wound bed is clean, pink, and healthy. Only then, maybe 4, 5, 7 days later, do you consider formally closing it. That discipline is what saves limbs and lives from infection.
It's an incredible amount to take in. This has been a really deep dive into Chapter 34. Let's try to summarize the absolute most critical anchors for everyone listening to take away for their revision.
Okay, logistically, remember, Larry, triage and rapid evacuation are the foundation of everything. Philosophically, burn this into your brain. Do the best for the most, not everything for everyone.
Clinically, you have to master the 4 phases of DCS. Remember that Phase 3, the ICU resuscitation, is where you allow physiology to recover before you go back for Phase 4 to fix the anatomy.
In terms of the wounds themselves, know the difference between the permanent and the temporary cavity. Understand that high-energy blast is the dominant injury, and that tissue elasticity determines how much damage is done.
And finally, the 2 surgical mandates that you cannot compromise on.
First, aggressive hemorrhage control. Second, vigilant, repeated control of contamination. That means serial debridement and delayed primary closure. Never close a dirty wound.
I think if you could take just one thing away from this, it's that conflict surgery is about making pragmatic decisions under incredible stress and accepting that the first operation is often deliberately incomplete to save the patient's life.
That's it perfectly, so use this as your framework. But for a final, provocative thought for you to chew on, consider the future.
Okay, what's a thought?
Given the rise of telemedical technology, where a senior surgeon can guide a junior surgeon remotely, and the fact that we're pushing advanced products like whole blood right to the point of injury, how is that going to change decision-making at a Roll 2 facility in the next decade?
That's a great question. If you can effectively start the resuscitation and lengthen that golden hour right there in the field, does the urgency to operate at a Roll 2 diminish?
Could that Roll 2 become less of an operating room and more of a super advanced resuscitation bay where you just stabilize patients for a safer trip to the much better resourced Roll 3?
So the definition of the golden hour might become obsolete, replaced by a continuum of care that starts the moment the medic arrives. The lines between the echelons of care are blurring.
The full texture, of course, is in the book. We really hope this deep dive has given you the framework you need to grasp these absolutely life-saving principles.
Until the next time we turn sources into insight, this has been the Deep Dive.